So here we go. This is a disclaimer slide. I'm going to talk about the epinephrine or Epipen, and all the information that I'm going to talk about is by my own personal and clinical opinion. Tonight, I'm going to talk about two different cases of anaphylaxis that we see here in Malaysia. The first one is medication. The second one is food. And when you should use epinephrine, how you should use it. So what is anaphylaxis? It sounds like a very, very sophisticated word, but it simply means a serious allergic reaction that is rapid in onset and can cause death. And these are all the symptoms that you can see. IgE-mediated anaphylaxis is what you might see when you do a Google search. It just means that the allergic reaction is mediated by this antibody called IgE. Foods are one of the major triggers. Venoms by stinging insects and medications. These are our top three triggers. The bottom ones, like natural rubber, latex, occupational allergens, aero allergens, radio contrast media, do occur, but they are lower down the list. So this is what we see in anaphylaxis or in severe allergic reactions. Your palms can become itchy and red. And you can see here swollen lips, which we call angioedema, and you can see here swelling on the face. You can see these itchy bumps all over the body, which we call urticaria, also commonly known as hives. Very, very itchy. Sometimes the hives can come together and form a large plaque and also can cause severe swelling at the same time. You might hear about anaphylaxis that is non-IgE mediated. This can occur from many other triggers. It's quite rare, but it does happen. Certain medications can cause IgE and non-IgE mediated reactions. Some other factors, including exercise, cold, heat, can trigger even alcohol. And also certain medications, which we call biologics, can trigger anaphylaxis from the non-IgE mediated pathway. So when you hear your doctor say IgE and non-IgE mediated, this is what they mean, because it is triggered by different antibodies and different immune mechanisms. Now, I'm going to start with the first case, called case A. This is what, as allergists, we see in our clinic. This is a young lady who has fever, cough, and shortness of breath. And she reports having allergy to an antibiotic causing itchy rash. And then, typically when we ask the patients, they will say, it's a white pill, but I don't know the name. I don't have any further information. Now, this is the dilemma, because this person has an infection that needs some form of an antibiotic. So what do you do? Well, let's talk about the myth. The myth is that the doctor can figure out my drug allergy easily. Actually, that is not true. Everyone thinks that there is a blood test that can be done that say, hey, you're allergic to these medications, don't take them. There's no such blood test that can diagnose what medication you're allergic to. What you should do, however, if you're allergic to the medications, you should find out the name of the medication and record it down. You can't trust your own memory. Over years, you can forget. You should also write down the type of allergic reaction you had. Even better, you should write down what medications you can take as an alternative. You say, look, I'm allergic to this antibiotic, but I can take this other antibiotic, no problems. So this is very important. Now let's proceed back to the case A. So she didn't know what antibiotic. She needed the antibiotic, so the doctor took a chance and prescribed Augmentin. So she went home, took Augmentin, and within 10 minutes, this is what happened. You can see here swelling of the lips. She also had shortness of breath, and she had to be rushed to the emergency room where she was found that her blood pressure was very low. So what's going on here? She's having a severe allergic reaction, which we call anaphylaxis. So she was treated then in the hospital and was given a diagnosis of penicillin allergy with a reaction of hives, swelling, and anaphylaxis. Now, this time she's much better. She remembered because 10 years later, she's scheduled for surgery and she told the doctor, look, I remember I have penicillin allergy and the medication is named Augmentin. So this is what you should look at and think about when you have a drug allergy or medication allergy. Write it down, write down the name, write down what happened. So why is it important to know what antibiotics you took that caused you to have the allergy and what other antibiotics you can take? The reason why is that just because you have penicillin allergy doesn't mean that you cannot take any other forms of antibiotics. Some antibiotics do not have reaction with penicillin, and so you can take that without having any issues. Also important to know is that if you have a diagnosis of penicillin allergy, this is not lifelong. Studies have shown that true allergy to penicillin decreases over time. Over a period of 10 years, 80% of people with true penicillin allergy will lose that allergy, which is important because if you have penicillin allergy and you might need that penicillin in the future, you should get tested. Because why? If you can take that penicillin, you can use a less toxic, more effective medication without causing antibiotic resistance, which is what we are dealing with nowadays. So how do you test for penicillin allergy? It's through skin prick tests. And you can see here, these are little needles that you can prick the skin, followed by intradermal testing in which you inject tiny amounts of the medication or the antibiotic under the skin. And if you are allergic, you have this allergic reaction, you look at it, it's like redness and swelling that looks like mosquito bite. This is what we call a positive skin test reaction, which means that most likely you're still allergic to that antibiotic. Now, if the test is negative, we then proceed on to what we call a drug challenge, either oral drug challenge or intravenous drug challenge to document that truly indeed you're no longer allergic to that medication. Now I'm going to switch gears and talk about the second form of allergy that we see quite commonly, which is food allergy. This is food allergy caused by the big 8 allergens. These big 8 allergens account for 90% of the food allergy that we see out there. Notice here that chicken is not on the list. Chicken allergy is actually very, very rare. Yeah. So we're seeing soy, milk, tree nuts, shellfish, wheat, peanuts, fish, and eggs. These are our most common food allergens. Now let's look at case B now. This is an 8-year-old boy with peanut allergy. And he used to develop rash around the mouth around 2 years old. And at 6 years old, he had a little bit of itchy rash like hives after eating peanut candy. Now, here's the thing, the parents didn't think it was that serious because he only had mild symptoms, which lead to myth number 2. Prior episodes of food allergy does not predict future reactions. In fact, food allergic reactions are very unpredictable because the sensitivity of the individual might change depending if they are healthy or sick, the amount that was eaten, other factors like asthma, taking any other medication such as painkillers. And you must always be prepared for an emergency if you have diagnosis of food allergy. So back to this boy, he was at a birthday party and he ate some biscuits. He didn't know it contained peanut and he complained of itching at the mouth. He then told his mom, who gave him some antihistamines. But 20 minutes later, despite taking the antihistamines, he broke out in a rash. And this is what we call urticaria. And on top of it, he started coughing. Now, fatal food anaphylaxis happens. Now, these are the statistics from the US. We don't really have much data here in Malaysia, but you get about 100 deaths a year in the United States from food allergy. Risk factors are asthma, symptom denial, especially in teenagers, delayed use of adrenaline or epinephrine, or previous history of severe reactions in the past. And the key foods are peanut, nuts, seafood, milk, and egg. These are the major triggers for anaphylactic food reactions that can lead to fatality. So why do we use Epipen? Why do we encourage people with food allergy to have an Epipen? The reason why we use an Epipen is so that we can administer the adrenaline or epinephrine quickly. And antihistamines, which is commonly used and prescribed, will not block anaphylactic reactions. Epinephrine is truly the only medication that can block anaphylaxis, and it works through all these pathways. It is the only medication that can do that, that can treat severe anaphylactic allergic reactions. So back to the boy. He started getting worse and they had to call emergency services. And look at him, he's in severe distress, lips are swelling, he's turning blue. You can see itchy hives and rashes all over the body. And the paramedics gave him epinephrine. When you give epinephrine injection, you get reaction and the effect of the medications within 10 minutes. It can improve the blood pressure. It can halt the anaphylactic progression. Why not antihistamines or even steroids? Antihistamines take a long time to work. And anaphylaxis is not caused by histamine alone. So antihistamines only block a certain portion of anaphylaxis. This is a study that showed that if you take diphenhydramine, which is a very common antihistamine, it takes 80 minutes before you see 50% suppression of histamine, which means that it takes a long time for antihistamines to work. Another thing is steroids. Steroids shouldn't be used because it takes even longer than antihistamines to work against anaphylaxis. It's a very slow onset of action. So all the guidelines say use adrenaline or epinephrine as the first line therapy. And why do you use an auto-injector? I know some people say, I'll carry the epinephrine with me, I'll draw it up. This is a study that compared just common parents versus physicians, general duty nurse, and emergency room nurses on how fast they can draw adrenaline in the real world. Now, this is in a real world situation, but it's not true anaphylactic. It's just to test, right? So it's not as stressful as when you see somebody really having a reaction in front of you. Emergency room nurses does the best, around 30 seconds. Normal nurses around 40 seconds. Doctors usually around 60 seconds. The parents can take up to 2 minutes or even longer, up to 6 minutes to draw out the adrenaline. So the time is of essence in this situation. Why do people fear using epinephrine? Well, here's the reason why. We see in TV, you know, this famous TV show called Pulp Fiction, and here you see the actor John Travolta and say you got to inject it into the heart, right? That's why people are afraid to use adrenaline, right? Epinephrine or auto-injectors. Actually, you don't inject it in the heart, and the epinephrine comes in a carry kit that looks like this. This is the Epipen for adults, and this is the Epipen for children. You can see different colors. And how you do it is you inject it into the thigh, right? You take the blue cap out and you inject into the thigh. You don't have to take off your pants, yeah? The needle will just go through your clothing. Just make sure you don't have your wallet or your phone there, yeah? That can prevent entry of the needle. So this is the final part of my talk, the conclusion. A few points I want to share with everyone out there. There is no simple blood test to diagnose drug allergy. If you have drug allergic reaction, please record it down, note the name of the drug, what happened, tell it to your doctor. Food allergic reactions can be fatal. And just because you had mild reactions in the past doesn't mean that future reactions will be mild. And finally, if you had allergic reactions, adrenaline or epinephrine is the main treatment for anaphylaxis. And that's about it that I like to share with you. I have many other speakers, and we want to have time for the Q&A session after this. Thank you for your time.